Dr. Flores hails from Mexico City. Don't let that fool you, he's linguistically gifted. He's fluent in Spanish, French, Italian, and English. He graduated from the University of Mexico and went on to pursue his internship at the Moncton City Hospital in New Brunswick, Canada. Completed residency training in internal medicine at Tulane University, New Orleans. At the Cleveland Clinic Foundation, he completed his fellowships. He's currently an instructor in medicine, Tulane Medical School, and in private cardiology practice now in Fort Lauderdale, Florida, from 1977 to 1996. He is the clinical assistant professor at University of Florida and Nova Southeastern, again from 1998 to 1999. So Dr. Flores, welcome. And you'll be talking to us about Cardiology New Specialties, cardiac oncology. Please welcome Dr. Flores.
Thank you very much. First of all, I thank you, the Society in Cayman Islands, to have invited us to this important event. And I feel honored to share the podium with professors like the ones we have listened already. It's fantastic lectures. And my talk is a talk that has developed out of necessity because a great amount of patients who reach older ages because of they have survived cancer, they are dying not from cancer, they're dying from heart disease. I will get this, I think. Can you get this out? Well, that's okay. So, and this is the problem. Oh. Well, we know that cancer is the number 3 cause of death in the United States after cardiovascular disease, after coronary artery disease and strokes. And because of the successful treatment that the oncologists have offered to patients in the last few years, the mortality has tremendously decreased. The mortality has, the survival rate has improved from 50 to 68% in the last 25 years. But still we have a lot of people that have underwent treatment for cancer, and there are now at least 12 million people survivors of cancer in the USA. So this success of treatment from the oncologist has a price. Obviously, they have different tools. Now they have a tremendous amount of drugs and a tremendous amount of research, sponsors, support, creating new drugs. Among them, probably, perhaps, the monoclonal antibodies that have changed completely the treatment of cancer. But when you use these drugs, you are trying to kill cancer cells. But in doing so, many times you kill also your own normal living cells in the body. And some of these drugs are known to do that in the myocardial cell and all the problems that ensues. And some of them, have heart failure, and patients that I'm sure Dr. Sheffield has treated with completely wiped out ventricles that end up having a different type of treatment for heart failure, such as resynchronization or even LVADs and transplants. So this has created in the last, let's say, we say 5 years, the need for a new specialty. Some centers like MD Anderson are offering already fellowships for cardiac oncology, and they're very active. I have been following this out of interest. I saw a few patients that were treated for breast cancer primarily that ended up having tremendous damage to the myocardium, ending with ejection fractions of 15–20%. And I saw that some of them were responding to treatment, and at the same time, were a lot of articles coming out in the literature in the USA and also in the rest of other countries in the world that showed that these patients may be helped. They may be helped if you identify them. They may be helped if you treat them at the same time that they are being seen by the oncologists, and also patients that have been treated for cancers many years ago. So This has brought the oncologists and cardiologists together to try to help these patients. As we said before, these anti-cancer drugs have no cardiac toxicity. We have identified mainly two types of toxicities. One caused mainly by a group of anti-cancer medication or anthracyclines. It has been used for many types of cancer, bone cancer, even lymphomas, and many other type of problems, such as doxorubicin, for instance. And we know this creates one specific type of toxicity that can be either acute or can be presented many years after, usually after 1 year after. What happens is that in the acute, these patients may develop cardiac arrhythmias, even ventricular tachycardia, or even more, atrial fibrillation, and they have to be dealt with. This is something that I remember when I was in training, that I saw patients that after infusions of anthracyclines, they develop arrhythmias, and all of us that have been in cardiology have dealt with this. And also some of these patients responded with a different type of problem, like myocarditis in the acute phase. But the more feared one, the more common, this has been prevented by the mode of infusion. The slower infusion has helped these situations. So we don't see many acute episodes. Besides, there are other anthracyclines, like epirubicin, for instance, that has less cardiac toxicity. In some studies, toxicity can be more common, can be up to about more than 20%, mainly when used either with radiation or with other drugs, such as the so-called taxanes, or also with the monoclonal antibodies. The type 2 toxicity is usually produced by the monoclonal antibodies or tyrosine kinase inhibitors. These drugs cause, again, a cardiac toxic effect directly with drops in the ejection fraction. And the good thing is that this one is usually it's not very common, but it happens in about 5-6% of the people. And again, when used with more than one drug, this percentage increases. And the good thing is that this is reversible with treatments for heart failure, usually. I will go into that. And radiation also causes severe problems. And this one would see that even kids that were treated for lymphomas at an earlier ages developed problems with the heart. I think all the surgeons hate to operate on these people because the valves are very thickened, the pericardium may be thickened, and even they have a constrictive pericarditis or physiology that are very difficult to treat at the time of surgery. Because the radiation affects mainly the endothelium of the cells, and also the fibrous tissue. So everything that has fibrous tissue or vessels in the heart is affected. So much, not so much the myocardium, which is very rare, but affects the vessels, coronary arteries, the valves, mitral valve and aortic valve, the pericardium, which causes typically acute or chronic pericarditis or constrictive pericarditis, and so that's usually very difficult for the future. And so the oncology therapists or radiation oncologists, to be more exact, have limited, or they have identified these problems, and now with newer techniques, with the localization of the area of radiation, and also using less doses of radiation, we know that they limit themselves to give no more than 40 gray units in the lifetime, have less problems. So when this is combined with chemotherapeutic agents, they drop the radiation to 30 gray units. So this is again discussing the type 1 toxicity, usually the anthracyclines. The type 2 that we said, usually the tyrosine kinase inhibitors, like a trastuzumab given for HER2 breast cancer. And the chest radiation that we spoke about. Just to give you an idea, these are all the drugs that can cause well, you see, these are all the drugs that can cause cardiac toxicity. It is of interest, I'm sorry, I apologize for the slides. It's very small writing, but at the left-hand side, you have the anthracyclines that, particularly the doxorubicin, causes what we mentioned before. But there are a group of drugs like the alkylating agents that, like the high cyclophosphamide, that usually causes, again, myocarditis. That, again, when we use with more drugs, or more than one drug, it can cause a problem. The taxanes or the paclitaxel that is used in stents from invasive cardiologists. And again, the targeted therapies with monoclonal antibodies, trastuzumab, is not common as a single agent, usually given with more other medications. The bevacizumab, which is Avastin, also can cause some myocardial damage, but that one is more prone to cause severe hypertension. That even the hypertension is an indicator the drug is working, so they say. But again, we have to deal with patients with severe hypertension. Another group is the fluorouracil capecitabine, which can cause acute coronary syndrome. It can cause, perhaps by coronary artery spasm, can cause severe problems and even cause myocardial infarctions. Again, this is more common, and then that can be treated, it has to be treated very aggressively from the beginning, and sometimes the drug has to be changed. So my point is just to see how many drugs are causing potential cardiac problems. This is another list. Again, see the Avastin, severe hypertension. Other drugs can cause, when combined with either anthracyclines or monoclonal antibodies. Okay, what's the cardiologist's role? The cardiologist's role is first to stratify these patients. With these patients, as mentioned before, the American population is aging, and you saw how many people are expected to be people over 65 to be survivors, or to be still living in the next few years. So after risk stratification, getting a detailed physical blood test and that to make sure the patients are not hypertensive or diabetics or have a history of coronary artery disease. And they need, of course, they need an echocardiogram and an EKG. Echocardiogram is probably the mainstay of the treatment in this type of patients. And also has to be a complete communication with the oncologist. As soon as the patient is identified, we have to talk to the oncologist and discuss what treatment they plan for the future, what the expectations are, what we're dealing with, and many times we make recommendations of what medications to start. Nowadays, even some medications can be given before any tests are given. I just saw an article called the PRADA, P-R-A-D-A study, in which candesartan may be used even before the treatment with anthracyclines or monoclonal antibodies is given. And then follow the patient. The patient usually goes through cycles with chemotherapy. We follow these patients at the time of the medication is given just before, during treatment, and even after treatment. Some of these patients may develop problems, mainly when anthracyclines are used, may develop problems in the future. Again, there has to be a continuous communication with the oncologist. So to summarize, the patient has to be evaluated before therapy, and assess comorbidities, as I mentioned before, with heart disease, coronary disease, hypertension, diabetes, advanced age, and the presence of valvular disease. And once we have that way obtained, we have to obtain some type of imaging of the heart, such as an echocardiogram, or in other places, like in Canada, they like more this nuclear stimuli angiograms. I don't know why, it's probably more expensive, but they like to do that. And the MRI for the heart, magnetic resonance, but that's very expensive, and it's not practical to be subjecting these patients to this test several times. The cost will be unsurmountable, but echo is usually the easier way to follow these patients. And with that, we use several factors. We use evaluation of first of all, the main thing is to check the ejection fraction, see how the left ventricular function is, see how the right ventricular function is, evaluate the valve function because it may be or may be abnormal at the time of treatment, which should make us think in a different way. We have to do transmitral Doppler and to see if they have any diastolic abnormalities, and the tissue Doppler again for the same reason. So we use all these modalities when we look at an echocardiogram. And the newest way to evaluate this patient, probably the most sensitive, is the use of some type of evaluation for myocardial deformation with a new technique called strain that many of the echocardiographic machines have now. So this is very important to get all these factors, and we can very much determine if the patient has any systolic dysfunction, to see if he has any diastolic dysfunction, to see if he has any deformation with the strain technique. Of course, the other parameters we usually use with an echo. On the management also, we need with some prognostic factors. Sometimes we use some markers, biomarkers. We usually use the troponin 1. Troponin 1 tells us if the treatment, mainly with anthracycline, has caused any myocardial damage. In people who have an elevated by troponin 1, we know that some damage to the myocardium has happened. So these patients prognostically don't do as good as the ones who do not have that. Also, the natriuretic peptides. So the evaluation of the BNP or the pro-BNP can tell us if the patient has heart failure. They are usually not, the peptides are released by the muscle, by the atrial muscle or the ventricular muscle, usually when there is any distension. So that's an indication of heart failure. Again, when the patients develop this, prognostically it has a different value. What do we do after all that information? Well, when there have been studies that even the use of statins before treatment has been effective. There's a study done actually in Cleveland Clinic that with the use of statins, that it showed some improvement in the ejection fraction. And probably the reason is because it has some stabilizing function on the endocardium of the vessels. And more important, the use of drugs that are used mainly for heart failures, so like the ACE inhibitors or the ARBs. And now with this study with the Prada, with candesartan, is interesting, and then we see what's going to happen. And use of diuretics if the patient has any congestive symptoms. And of course, we have to treat all the comorbidities. And also, we need to follow this patient with serial echocardiograms, one usually at the time of treatment and usually every 3 months until the treatment ends, and usually for 1 year, not necessarily every 3 months, but depending, and each one is specifically. Again, all of this has to be through communication with the oncologist. Always communicate with the oncologist. Sometimes we have to hold the therapy when there is any drop in the ejection fraction. And we see this all the time. With these medications, the ejection fraction drops, and we hold the treatment for another month, and we repeat the test. And usually, amazingly, the ejection fraction starts coming up again, and or other factors. Many times this heart failure is subclinical, so this is something very early. So in summary, we have to communicate with the oncologist all the time. We have to see these patients early and follow them very closely. At Holy Cross Hospital, we have been doing that since 2013. And initially, there weren't any guidelines. Now we have some guidelines. They're even reported in the American Society of Echocardiography and also in some of the cancer journals have been described. And through cardiac oncology clinics, which is a multidisciplinary group, usually by the cardiologists, oncologists, whenever there is any problem, we send the patients to the heart failure clinic. And usually it's not only one decision. So we have to have a team, and we have to continue to have the most communication that we can get, we can get. So we have to communicate all the time with the oncologists and everyone involved in this group. So I don't know if there is any question or comment. Thank you very much.
Oh, I think we have one question from the audience.
Yes, thank you very much for that wonderful presentation. At the moment, you say that when the patients, oncology patients, are getting chemotherapy, is it now standard of care that immediately they start on chemo, or after they finish the first round of chemo, that they actually have a consultation or an echocardiogram by the cardiologist?
No, it's not the standard of care yet, but it probably will come that way.
Yes, because I've certainly looked after quite a number of patients from the United States who are, ovarian cancer patients that had undergone 3 or 4 rounds of chemotherapy,
Exactly,
and yet they have never, I questioned them, have you ever been to see a cardiologist? Have you ever had an echocardiogram? And the answer is no. So at the moment, what they're waiting for is until the patients actually exhibit, shortness of breath, some sort of cardiac failure before they refer.
Well, I think the oncologists are very much aware that some of the drugs that cause these problems, they are all aware, as I have seen, that anthracyclines cause a drop in the ejection fraction that sometimes irreversible. They know that treatments for breast cancer can cause the same thing. They know it's worse when they use a combination of more than 2. So they usually order an echo. And after that, they used to call, sometimes they continue the treatment. Was nothing organized, but now that's essentially the reason why we need a clinic. Now we have spoken to the oncologists, and they're all very interested. And the oncologists actually, they're afraid of cardiac drugs. As much as we cardiologists are afraid of chemotherapeutic drugs. We don't like to hear about that, and they don't either. So they, when they see that there is this facility to treat the patients, they welcome it I have had excellent response from them. And whenever something different, for instance, in one time, one patient was having angina, a young patient with colon cancer that was capecitabine, which is like a fluoro 5-FU. Fluorouracil. She started having chest pain and with EKG changes. So we were able to hold the therapy. We put her on a high dose of vasodilators, and she tolerated it after that. We didn't get a troponin 1, she didn't get it, but probably it was having a coronary spasm. And like that, there are many patients, mainly for breast cancer, that actually we have seen patients from Cayman Islands. 2 patients that we were seeing that during the treatment, they had a drop in the ejection fraction, and we held the treatment for a month. We continue with, we increased the dose of beta blockers and ARBs, and the ejection fraction came back up. So this is very rewarding. Believe it or not.
Well, it'll certainly be welcomed, I think, when it becomes standard of care. Like I say, a lot of these patients now we're diagnosing with breast cancer and ovarian cancer, survive, but they have relapses and they go back into chemotherapy, and yet I have to see one, consultation with a cardiologist or an echo. So I certainly hope that we are going in that direction.
Yes, I think, all the big centers in the USA have cardiac oncology clinics. Actually, we were Holy Cross was one of the first at least in South Florida, to have this type of clinics, and we have been working more than 2 years already. So we are acquiring a lot of, not a lot, but some experience in that, equal to the other centers such as the Mayo Clinic or Cleveland Clinic. They do have these clinics for already 2 or 3 years. I remember that I talked to one physician in Mayo Clinic when I was interested in this topic, and I saw there was an article published by the Mayo Clinic Proceedings. I discussed with him, and at the time they didn't have any guidelines. It was just like an interest in some patients that are not doing too good and no one is paying attention to until they are in trouble, until we have to deal with heart failure. But they started to progress that, and now there are many centers have that. And now you go to an echo meeting, and it's not much you can hear. You can listen to all the monoclonal antibodies, all the cardiac toxicity. You talk about all the echo findings about strain in all the meetings in cardiology, and mainly in echocardiography, which is more of my interest. So this is a very important topic. And now, if there is communication, call it clinic or not, but if there's any communication between oncologists and cardiologists, it's good for the patient. Because let's face it, patients are getting older. Patients are dying not of cancer, they're dying of heart disease. And many times, heart disease, I mean heart failure, and that's not acceptable. We have to try at least help these patients at most. Sometimes they're at the end, so they have to go to see the doctor in Cleveland Clinic. So this is an important topic, and I think it's growing. It's a lot. We're learning a lot with more centers interested in that. As I said, for MD Anderson, he's offering fellowships in cardiac oncology. So they have cardiologists in there. Some centers have cardiologists in the staff, already, so to treat this type of patients, and they're working together, which is what we are trying to do, and it's working well in our institution.
If I might exercise a little MC's privilege, I think what this has shown is that no matter the segregation of medical disciplines, the patient unites us all.
Yeah, just all work multidisciplinary, like Dr. Sheffield, we have to work together.
Absolutely. It is a multidisciplinary approach. Thank you.